Welcome back to the deep dive, where we really get into your core source material to pull out that clinical knowledge you absolutely need. Today, we are tackling a really critical topic, high-stakes stuff, preventing adverse drug reactions and, well, dangerous drug
Yeah,
interactions.
this is absolutely foundational for advanced practice. And the sheer scale of the risk, it just makes this discussion essential. There was one prospective study. It showed that 3.6% of all hospital admissions were directly caused by serious adverse drug reactions, ADRs.
Wow, 3.6%. And what's really alarming, especially for, improving patient safety, is that apparently 30% of those admissions were preventable.
30% preventable. And that translates directly into, well, billions of dollars lost. Could be up to $30.1 billion a year just in the U.S. from longer hospital stays and readmissions. So our job today is really to understand the framework, how and why drugs kind of misbehave when they're combined.
Right, combined with other drugs or food or even patient conditions. So we're breaking this down into four main interaction categories: drug-drug, drug-food, those complementary alternative medicines or CAMs, and drug-disease interactions.
And the mechanism underneath it all is always the same, really.
Yeah.
These interactions mess with either the drug's pharmacokinetic profile, that's the ADME journey,
Hmm.
absorption, distribution, metabolism, excretion, or its pharmacodynamic profile, the actual effect it has on the body.
Okay, so let's follow that journey, starting with absorption, right there at the gateway, the GI tract.
Exactly. The chemistry kicks in immediately. And one of maybe the most straightforward issues is the pH problem.
Ah, acidity.
Yeah. If a drug needs a really acidic stomach to dissolve properly, ketoconazole is a classic example, and the patient is also taking something that neutralizes that acid, like, say, an antacid or even a PPI like esomeprazole.
Then the drug just doesn't get absorbed properly.
Precisely. You're basically blocking it from getting into the bloodstream in the first place.
Okay, and then there's the binding problem, adsorption, sometimes called chelation, right, involving metal ions.
Exactly that. You've got these divalent or trivalent cations, think magnesium, aluminum, calcium. They're common in antacids, some vitamins. They act almost like tiny magnets.
Agra.
Well, they latch on to certain drugs. Tetracyclines and fluoroquinolones are the big ones here. And once they form that complex, that sort of chemical package, it just can't get absorbed.
Wait, hang on. So if I prescribe, say, tetracycline, and my patient pops a calcium supplement or Tums at the same time, that tetracycline might just be useless.
That's pretty much it. It can drastically reduce absorption. The key clinical pearl here isn't just knowing which metals. It's realizing that if a drug binds to anything that's just sitting there in the gut, the solution is always time. Separation.
Okay, how much time?
Well, the source material is clear. Give the target drug at least 2 hours before the interacting agent, or wait 4 to 6 hours after. That usually gives enough separation to prevent that binding in the gut.
Got it. Okay, let's track how GI motility plays a role. You mentioned metoclopramide speeds things up.
Right, increases gut speed, so it can actually increase the rate of absorption just because the drug gets to the duodenum, the main absorption site, faster.
But what about slowing things down, like with opioids or anticholinergics?
Yeah, they decrease the rate of absorption. But what's interesting, and this often means it's less clinically significant, is that even though the drug takes longer to hit its peak level,
The total amount absorbed is usually the same.
usually, yeah, the total bioavailability often doesn't change much, just the timing of the peak.
Okay. Before we leave the gut, quick word on GI flora. We know antibiotics disrupt bacteria, but how does that mess with drugs?
Oh, it definitely can. For certain patients, antibiotics like erythromycin or tetracycline can wipe out the specific gut bacteria that normally metabolize digoxin.
Ah, so less metabolism in the gut.
Means more digoxin gets absorbed systemically. You get higher bioavailability, potentially dangerous increases in serum levels. And the flip side is sometimes seen with oral contraceptives disrupting gut flora might interfere with the reabsorption of active contraceptive metabolites, potentially lowering efficacy.
Okay, drug absorbed. Now, distribution. Let's talk protein binding. Only the unbound drug is active, right? Plasma proteins are just like taxis.
That's the core concept. And the critical point for a significant interaction, the real danger zone, happens when drugs meet two criteria. They are more than 90% protein-bound, and they have a narrow therapeutic index, NTI.
Right, NTI drugs. Just to remind everyone, that means the effective dose is really close to the toxic dose. Very little wiggle room.
Exactly. And warfarin is the absolute poster child for this risk. It's about 99% bound to protein. Only 1% is free and doing its job.
Only 1%.
Yeah. So now imagine another drug comes along and displaces just 1% more of that bound warfarin off the protein.
Okay, so now 2% is free instead of 1%.
You've instantly doubled the amount of active free drug from 1% to 2%.
Now, wow, doubled just from a tiny shift.
Yeah.
And that translates directly to
Major bleeding risk. It really highlights how critical understanding protein binding is for these high-risk NTI drugs. Table 3.2 in the source has more examples, like sulfaphenazole displacing phenytoin.
okay, precision is vital, which leads us straight into metabolism mayhem driven by the Cytochrome P-450 system, CYP-450.
Right. This is the body's main chemical processing plant, especially for phase I reactions. It basically takes fat-loving lipophilic drugs and converts them into water-loving hydrophilic ones so the kidneys can get rid of them. Mostly happens in the liver.
And the naming, like CYP3A4, tells you the family, subfamily, and gene.
Yep. That's the nomenclature. Family 3, subfamily A, gene 4 for that one. But clinically, you don't need to memorize hundreds. They're really just a handful that cause most of the problems.
The big five.
We call them the big five, yeah. They handle something like over 90% of clinically significant interactions. CYP3A4 is the king, metabolizing 40–35% of drugs.
40 to 45%. Wow.
Then comes CYP2D6, handling maybe 20–30%. And then you have CYP2C9, CYP2C19, and CYP1A2 rounding out the major players.
And this is where individual genetics, pharmacodynamics really changes the game for patients. How often does this actually impact prescribing?
Oh, frequently. Take CYP2D6. Around 10% of Europeans actually lack a functional version of this enzyme. They're poor metabolizers.
So what happens to them?
Well, two things. If they take a drug normally broken down by 2D6, it sticks around longer, builds up, increasing the risk of ADRs. But maybe even more critically, if you give them a prodrug.
A drug that needs that enzyme to become active.
Exactly. Like codeine needs CYP2D6 to become morphine, or tamoxifen needs it for its active metabolites. If you're a poor metabolizer, you get little or no therapeutic effect from those drugs.
Total treatment failure just based on their genes. Okay, so let's talk about the two main ways we mess up this system. First, enzyme inhibition, stopping the machine.
Right. Inhibition means the enzyme is blocked, so the drug it normally metabolizes builds up. Higher concentrations, more potential for toxicity. An inhibitor drug can compete for the enzyme's active site, or it might bind elsewhere and just change the enzyme's shape so it doesn't work that's non-competitive, like quinidine does to CYP2D6.
And how long does this blocking effect last?
It really depends on the half-life of the inhibitor drug.
Some are really long, right?
Oh yeah. Look at amiodarone. Its half-life is around 53 days. So even after a patient stops taking it, its inhibitory effects on various CYP enzymes can linger for weeks, even months. You have to be super careful starting new drugs after amiodarone.
Wow, okay. And dose matters too.
Definitely. Some drugs like cimetidine or fluconazole are dose-dependent inhibitors. The higher the dose, the more inhibition you get.
And the clinical consequences here are usually toxicity, like the simvastatin example.
Yes, simvastatin is metabolized by CYP3A4. Add a potent 3A4 inhibitor like ketoconazole, simvastatin levels skyrocket, and you risk rhabdomyolysis, muscle breakdown.
Or the warfarin one again.
Classic. Warfarin is metabolized by CYP2C9. Add TMP-SMZ, which inhibits 2C9, and the patient's INR shoots up. Massive bleeding risk. But inhibition isn't always bad. Sometimes it's used beneficially, like using ketoconazole to inhibit cyclosporine metabolism, allowing lower, less toxic cyclosporine doses.
Okay, interesting. And sometimes inhibition reduces efficacy, right? If it's a prodrug.
Exactly. Clopidogrel, the antiplatelet drug, is a prodrug. It needs CYP2C19 to become active. If you give it with a C19 inhibitor, like the PPI meprazole, you actually reduce its antiplatelet effect. Less activation, less benefit.
Okay, that's inhibition. Now the flip side, enzyme induction. Speeding up the machine.
Right. Here, one drug stimulates the liver to actually make more of certain enzymes. More enzymes mean faster metabolism of other drugs using that pathway.
Leading to lower levels of the target drug.
Exactly. Lower levels, potentially treatment failure. The key inducers to always remember are drugs like rifampin, phenobarbital, phenytoin, carbamazepine. They're notorious.
And lifestyle factors play a role here too, you mentioned.
Absolutely. Chronic heavy alcohol use can induce certain enzymes, speeding up drug metabolism. And smoking is a big one. The polycyclic aromatic hydrocarbons in tobacco smoke induce CYP1A2.
Which affects which drugs?
Theophylline is a classic example. Smokers often need higher doses of theophylline because their induced CYP1A2 enzymes chew it up much faster.
Okay, so with induction, timing is different than inhibition, right? Because the body has to actually build more enzymes.
That's the key difference. Induction takes time, Enzyme production and degradation has its own turnover rate, maybe 1 to 6 days. So while an inducer like rifampin might start signaling the liver within 24 hours,
You don't see the effect right away.
right, its full effect on, say, warfarin levels might not be apparent for maybe 4 days or even longer as those enzyme levels build up.
Yeah.
They have to anticipate the drop in the target drug's level.
And a huge clinical consequence here is rifampin and birth control, isn't it?
Yes, absolutely critical. Rifampin is a potent inducer of CYP3A4, the main enzyme metabolizing oral contraceptives. So taking rifampin can dramatically lower contraceptive levels, leading to failure and unintended pregnancy. Always counsel about backup contraception.
Okay, absorbed, distributed, metabolized. Time for the exit strategy, excretion. Kidney's the main route, but urine pH can really change things.
It sure can. Changing the urine pH alters whether a drug is ionized or non-ionized. Remember, only non-ionized drugs easily cross back from the urine into the bloodstream.
So making the urine more alkaline.
Right, like giving sodium bicarbonate increases the ionization of acidic drugs like aspirin. More ionized means trapped in the urine, so excretion is faster. But that same alkaline urine decreases the ionization of basic drugs, like pseudoephedrine or quinidine.
Meaning they get reabsorbed more.
Exactly. Less excretion, potentially higher levels.
And then there are those traffic jams in the kidney tubules, the active transport saturation.
Yeah, when two drugs rely on the same molecular pump or transporter to get secreted into the urine, they can compete, like a bottleneck.
Can be good or bad.
Right. It's good with probenecid and penicillin. Probenecid blocks penicillin secretion, keeps penicillin levels higher for longer, boosting the antibiotic effect. But it's bad, potentially dangerous, when digoxin and verapamil compete for the same transporter. Digoxin levels can rise, increasing toxicity risk.
Okay, and this transporter idea brings us to P-glycoprotein, PGP. That's not just in the kidney, right? It's kind of like another layer of control.
Exactly. PGP is like a cellular bouncer. It's an energy-dependent efflux pump, found in the gut lining, liver cells, kidney tubules, even the blood-brain barrier. Its job is to actively pump drug molecules out of cells.
So in the gut, it pumps drugs back into the lumen, reducing absorption.
Yep. And in the kidney and liver, it pumps them into the urine or bile, increasing excretion. It's another defense mechanism.
So just like CYP enzymes, PGP can be inhibited or induced.
Precisely. If you inhibit PGP, the bouncer is slowed down. More drug gets absorbed in the gut, less gets pumped out by the liver and kidney. Net result, higher drug concentrations.
Like quinidine and digoxin.
That's a classic PGP interaction. Quinidine inhibits intestinal and renal PGP, leading to significantly higher digoxin levels. Conversely, if you induce PGP,
Like with rifampin again.
like rifampin,
Yeah.
it induces intestinal PGP. So if a patient is taking digoxin, rifampin makes the gut pump out more digoxin before it can be absorbed. Lower absorption, lower levels, reduced effect. Table 3.5 in the source lists common PGP substrates, inhibitors, and inducers. Really useful clinically.
Okay, we've mapped the internal chaos, the acids, enzymes, transporters. Now let's talk about the stuff that walks in the door with the patient, starting with drug-food interactions, DFIs.
Right, and the mechanisms often mirror what we just discussed with ADME. We already mentioned chelation milk products binding tetracyclines as a food interaction.
Physical barriers, too.
Yeah, food in the stomach can just physically block drug absorption sometimes. Azithromycin bioavailability drops by like 43% if taken with food. That's why Box 3.1 lists drugs needing an empty stomach, like erythromycin or isoniazid.
And the most famous food-drug interaction involving metabolism has got to be grapefruit juice.
Ah, yes, grapefruit juice. It's a potent inhibitor, specifically of CYP3A4 enzymes located right in the intestinal wall,
Just in the gut, not systemically.
primarily in the gut wall.
Yeah.
But because it stops that first-pass metabolism right at the absorption site, it dramatically increases the bioavailability, the amount that gets into the bloodstream, for drugs normally heavily metabolized by intestinal 3A4.
Like certain statins or calcium channel blockers.
Exactly. Philodamian, simvastatin, their levels can increase significantly, raising toxicity risk. And this effect isn't short-lived. It can last up to 24 hours after drinking the juice.
Wow, okay. And pharmacodynamically, food interfering directly with the drug's action.
The classic is warfarin versus vitamin K. Eating lots of leafy greens rich in vitamin K directly counteracts warfarin's anticoagulant effect.
But the really dangerous one is MAO inhibitors.
Extremely dangerous.
Yeah.
MAO inhibitors block the breakdown of tyramine, an amino acid found in aged, fermented, or cured foods, aged cheese, salami, soy sauce, some beers. Normally, tyramine from food is broken down in the gut, but with MAO inhibitor.
It gets absorbed.
Gets absorbed systemically, floods the system, and triggers a massive release of norepinephrine and epinephrine from nerve endings. The result can be a hypertensive crisis, soaring blood pressure, headache, potentially stroke, life-threatening.
Definitely need to counsel patients on MAOIs about that diet.
Okay, that leads us nicely into complementary and alternative medicines, CAMs. You mentioned 33.2% of U.S. adults use them. We absolutely cannot assume natural is safer.
Never assume that. They're largely unregulated, potency varies wildly, and interactions are common. Some are pharmacokinetic. Fiber-rich products like psyllium or acacia can physically bind drugs in the gut, reducing absorption similar to food effects. Affects things like amoxicillin, carbamazepine, digoxin.
But the metabolism effects are where the big dangers lie, right? St. John's wort.
St. John's wort is probably the most notorious CAM for interactions. It's a potent inducer of both CYP3A4 and P-glycoprotein.
Ah, the double whammy again. Inducing the breakdown enzyme and the pump that kicks the drug out. Exactly. So it drastically lowers plasma concentrations of many critical drugs, immunosuppressants like cyclosporine, warfarin, oral contraceptives, some antivirals, leads to treatment failure, organ rejection, unintended pregnancies, resistance. It's a huge risk.
And we also need to ask about CAMs that affect bleeding risk with anticoagulants or antiplatelets.
Absolutely. Things like ginger, ginkgo, ginseng, even high-dose fish oil can increase bleeding risk. Box 3.4 summarizes some key ones. Also, things like kava or valerian root can potentiate the effects of CNS depressants, benzos, opioids, alcohol, leading to excessive sedation.
So always ask about CAMs. Okay, finally, drug-disease interactions. How the patient's underlying conditions change drug handling, or how drugs worsen conditions.
Right. Disease states profoundly alter pharmacokinetics. Obvious examples. Severe liver disease or advanced heart failure drastically reduces metabolic capacity.
And kidney disease.
Renal insufficiency is huge. Once creatinine clearance drops below about 50 mmol, you really need to start thinking about dose adjustments for renally cleared drugs like H2 blockers, many antibiotics, digoxin. Even something like diabetic gastroparesis can slow down oral drug absorption unpredictably.
And then there's the drug making the disease worse.
Yeah, Table 3.8 gives great example. Anticholinergic drugs can worsen urinary retention in men with BPH or worsen confusion in patients with dementia. NSAIDs are notorious for worsening chronic kidney disease or precipitating heart failure exacerbations. You always have to consider the drug's effect on all the patient's conditions.
Okay, pulling this all together, it's all about preventing adverse drug reactions, ADRs. Let's quickly define that again.
Sure. An ADR is basically any response to a drug which is noxious, unintended, and occurs at doses normally used for prophylaxis, diagnosis, or therapy.
And there are different types.
We often think in terms of type A and type B. Type A reactions are basically an exaggeration of the drug's known pharmacologic effect. They're dose-dependent, predictable, like getting too much dry mouth from an anticholinergic or too much sedation from a benzodiazepine. It's just too much of the intended effect.
Okay, predictable. What's type B?
Type B reactions are bizarre, unpredictable, not related to the known pharmacology, often immunologic or idiosyncratic. Think drug-induced liver injury, Stevens-Johnson syndrome, anaphylaxis. These are much harder to predict and often more severe.
And alongside ADRs, we just have to be constantly vigilant for basic medication errors too, right?
Absolutely. Simple slips, look-alike, sound-alike drug names like accidentally grabbing phenylephrine instead of metoclopramide from the Pioxis. Using dangerous abbreviations. These are errors in the process that can lead to harm, separate from inherent drug interactions or ADRs.
Okay, so wrapping this deep dive up, what's the core message for practice?
It really boils down to prediction and prevention. Most significant drug interactions are predictable and therefore often preventable. But that prediction requires knowing your pharmacology.
You need to know the drug's properties. How much protein binding? Which CYP pathway it uses? Is it a PGP substrate or inhibitor or inducer? What's its half-life? You need that info before you prescribe or make changes.
Exactly. Which leads to a final provocative thought for you, the listener, to really mull over. Given how complex this CYP system is, with all the potential for inhibition and induction, and knowing that about a third of adults are using CAMs, often without telling us, how thoroughly are you asking about everything?
Yeah, not just prescriptions.
Everything. Over-the-counters, herbals, supplements, dietary changes like starting grapefruit juice. Are you digging deep enough? Because failing to ask about that St. John's wort or not realizing the impact of adding an inhibitor could cause a disastrous metabolic shift, undermine therapy, and lead directly to a preventable ADR.
That comprehensive medication history, including all those extras, it really is your first line of defense. Powerful reminder.
Well, thank you for walking us through that complex landscape. This has been incredibly valuable.
My pleasure. It's critical information.
And from all of us here at the Last Minute Lecture team, thank you for listening and engaging with this deep dive.